Okay, it's me again, Sarah Galar. Now we'll discuss again with you just the second part of lectures 4, fourth lectures. We can experience the acute tonsillitis during the hematologic disease also. Hematologic disease may experience it as a monocytic, leukocytic angina. Affection of the pharynx in systemic diseases, we mean that this is infection. This is probably caused by the special lymphotropic virus which occurs together with the Listeria genius. We mean Epstein-Barr viruses during the infection mononucleosis. It is believed that infection occurs by airborne droplets or by contact. The nasal cavity and the pharynx are the portals of infection. Children and the young usually develop mononucleosis. The disease is characterized by a fever, tonsillitis-like changes in the fauces, splenomegaly, and changes in the blood. At the onset of the disease, the body temperature rises to 840 degrees and persists at this level from 5 days to 4 weeks. The symptoms are sometimes elevated periodically during this stage, and early the permanent sign of disease is enlarged lymph nodes, first on the neck and then in the groin, armpits, in the abdomen. The spleen and the liver are also enlarged in most patients. Changes in the pulses usually follow the enlargement of lymph nodes, and they are similar to those occurring in lacunar fibrosis and less frequently necrotic tonsillitis. The most characteristic symptom of the disease is a moderate leukocytosis with a predominance of mononuclear cells, which may number 50 to 90% of the total leukocytes, a great number of altered monocytes. The treatment is the bed rest and high-color diet rich vitamins are prescribed, and antibacterial medications, I mean just the antibacterial drugs we are using to prevent the secondary infection. The causative agent because it's insensitive to them. Why? Because it is the causing factors is the virus, microorganism. And general with disinfectant or solutions is usable. Necrotized areas are treated with a 10% of silver nitrate solution. Infectious mononucleosis, another names, we can call it as a glandular fever and kissing disease. The Epstein-Barr virus known for causing infectious mononucleosis or kissing disease. In addition, the virus has been linked to several specific cancers, including nose and throat cancers, stomach cancers, and lymphomas cancers in the lymphatic system, including the spleen, tonsils, and tumors. Also, the symptoms of infection mononucleosis usually resolve in 1 or 2 months. Epstein-Barr virus remains dormant or latent in a few cells in the throat and blood for the rest of the person's life. Periodically, the virus can reactivate and is commonly found in the saliva of infected persons. The second types of hematological disease is the agnocytic angina. Infection of the tonsils is the specific symptom of this disease. Agnocytosis is considered not as an independent nosological disease but as a response of the hematopoietic system to various pathological factors such as the infection, radiant energy, or as a result of altered hemopiesis in systemic disease of the blood. Agnocytosis occurs mostly in women. It is a rare disease affecting mostly adults. The symptoms of agnocytosis, agnocytic angina, is the prodromal period is characterized by indisposition. It lasts 1-2 days. Phlegmonic acute and subacute forms of agnocytosis are distinguished. In the former two cases, the disease begins with a high temperature, chills, and bad general condition. Necrotic and ulcerative changes in the pharynx, mainly in the region of the palate and tonsils, occur simultaneously. Necrosis often spread onto the mucus of the pharynx, gums, and the larynx. In rare cases, the destructive changes occur in the intestine and the urinary bladder. Necrosis can extend onto deep underlying soft tissues and bones. The blood is characterized by a very low count of polymorphonuclear leukocytes or they can be absent. Treatment is aimed at activating the hemobiotic system and control secondary infection. Exception of all medicines that can cause agranulocytosis, such as the endocrine limits and each other's blood transfusion, antibiotic therapy, hormone preparations, and others means of treating agranulocytosis are prescribed. The diet should be sparing. The patient must gargle the salts with antiseptic solutions. The necrotizing matter should be removed. Now, in that slides, we can see the differentiation of the agranulocytar and the infection mono. I mean, it's just a kissing tonsils or infection mononucleosis. You see the agranulocytar angina, their age range is more than just 15 years. Their blood test, during the blood test, we can see the leukopenia, I mean the decrease in the leukocytes, even it may experience it as a 500, 150, and it may lead to sepsis odor in mouse. During the infection manner, it is the characteristic. It's the last stages. Just it's also the symptoms depend on the concentration of this virus, but the skin rash, loss of appetite, soft swollen spleen, inflammation of the liver, I mean adenoid hepatosplenomegaly, all of these are the significant signs of infection mono, and we can see the age bar is in between just the early age, but now contemporary days it's reported that now we can see in adult patients also is the infection mononucleosis patient disease. Banal acute during the banal acute disease, the general intoxication should be, and the pathological clinical findings we should find in both cancers. Sometimes during the atopic types, for example, during the Wilson's angina, we can see the changed ulcers in the one tonsils. The characteristic view, but characteristically during the banal problems, banal acute diseases should be the two of them, both tonsils should damaged. And duration the 7 days. I mean that after the 7 days, if it is the banal acute tonsillitis, I mean the follicular membranous, it should be last just the 7 days. The 7th day should be the last day. If it lasts more than 7 days, it means that there is another problem. Maybe measle, maybe just a diphtheria. First, we should just suspect the diphtheria or any others atypic or hematological diseases. That's why during the acute tonsillitis patient, we should send the patient to the blood test. I mean, the first routine is the swab, test, and we call this a strep test. If the strep test is negative, because during the banal acute disease, it is the GABHS should be reason. If the strep test is negative, we should look for another causative reason. Okay, now I want to show you the tonsils. PT were so swollen they are caused the respiratory distress, necessitating their sometimes the tonsillectomy. But you should remind that during the acute tonsillitis, during the period of acute tonsillitis, we cannot do the surgery. We cannot touch them. Palatine tonsils, which are bright red, swollen, and decoated. In that picture, we can see the throat cultures are the criterion standard for the detecting group A beta-hemolytic streptococcus, because the sensitivity there's a 95% for antibiotic therapy. But during the viral tonsillitis, we shouldn't do just antibacterial therapy. The treatment, the gold standard is the bed rest of diet, plenty of fluids, warm sealing, gargles, and sometimes we are using analgesics and antimicrobial therapy for 7 days. Now about the complication. There's a complication. Maybe we can say this as a paratonzillar abscess, whereas a parapharyngeal abscess, and any others complication it can lead to. But the visible one is paratonzillitis. Inflammation of the paratonzillar cellular tissue arises due to viral infection spreading, usually from the palatal tonsil to the paratonzillar cellular tissue in the presence of predisposing local and general factors. The symptoms, it's the development of the process has 3 stages. The infiltrative stage, the second is the purulent reconvalescence stages. The process is usually unilateral. Tonsillogenic tonsillitis occurs several days following recurrent exacerbation of chronic acute tonsillitis. Okay, it is the inner life. Previous picture we saw as a schematic picture. Now it is the alive patient's pictures here. Another names of the paratonzillar abscess is the paratonzillar abscess. We call it the quinsy. So you see the swelling and erythema above the left tonsils. The uvula is slightly swollen as well compared to the right paratonzillar area, which looks normal. Okay, it is the another pictures. It is the another patient's picture. You see, it's the uvula change in the position. Why? Because in opposite side, the paratonzillar abscess just oppressed it. How we can treat it? What we should do? The patient must be hospitalized. Bed rest is obligatory, and bacterial therapy is indicated for all stages of paratonzillitis. Antibiotics are injected intramuscular as soon as the abscess is dry. In the 3rd or 4th day, it should be opened surgically without waiting for its spontaneous rupture. The abscess is usually incised without any anesthesia or after spraying over the pharynx with a 10% of the kind solution. The incision should be done at the most prominent site. The tonsillectomy indicates in cases when the opening of abscess is impossible. I mean, just the lateral paratonzillitis, abortive attempt to open the abscess, persistent course of the disease, and the presence of signs of complications such as the sepsis, parapharyngeal abscess, phlegmonic of the neck, and the mediastinitis. Okay, the drainage should be from this point. How we can do this? We just imagine one horizontal axis base of the uvula. Just follow my arrow, and it's the vertical line from here and joining area. We should do this area. We should do in this point. We should do the drainage. You see here it is that this patient is under general anesthesia. We just opened it. You see it is the tongue is superiorly located. It is displaced right tonsils. In this area it is the right paratonzillar abscess, and here in that pictures it is the incision and drainage of the right paratonzillar abscess. After the incision, the pus flowing from incised abscess. What's the retropharyngeal abscess? This is a purulent inflammation of the lymph nodes and loose connective tissue found between the fascia of the pharyngeal muscles and the prevertebral fascia. The disease occurs almost exclusively in children because the lymph nodes and the loose connective tissue in this region are well developed up to the age of 4, after which they undergo involution. The first symptoms are usually pain in the throat during swallowing and impeded respiration. The child refuses food, becomes restless, and often cries. Sleep is deranged. The temperature rises to 9 degrees if the abscess is found in the nasopharynx. Respiration through the nose becomes difficult, speech is nasal, and the voice timbre is dull. In that picture, you can see the X-ray of the neck because the imaging techniques are useful to show the location and extent of the infection. The lateral X-rays show soft tissue swelling in most patients. Here we can see the swelling. Parapharyngeal abscess is a deep neck abscess treated with antibiotics and the surgical drainage. Pharyngeal abscess has a higher risk of airway obstruction. The presentation of pharyngeal abscess is typical with severe sore throat, pharyngeal edema, cervical lymphadenopathy, and neck rigidity. How we manage pharyngeal abscess? The first standard, we should use the broad spectrum agents with anaerobic covers should be used. The surgical drainage usually leads to rapid improvement, so drugs can be switched from forced oral within the first 48 hours, provided the patient is able to swallow. Complications with pharyngeal abscess are secondary to mass effect, the rupture of the abscess, repeat of infection. The most urgent complication involves the abscess expanding against the pharynx or trachea, causing airway compression. Rupture of the abscess can cause aspiration of pus, resulting in asphyxiation or pneumonia. Mediastinitis, purulent pericarditis, and tamponade pneumothorax may happen. Spread of the infection to the mediastinum can result in pleuritis, emphysema, or bronchial erosion. The posterior spread of infection can result in osteomyelitis and erosion of the spinal column, causing vertebral subluxation and spinal cord injury. The infection itself can evolve into necrotizing fasciitis, sepsis, and death. Spread of the infection laterally can involve the carotid sheath and cause jugular vein thrombosis or carotid artery rupture. Lemierre syndrome, what is it? We call this the tonsillogenic sepsis. Now, during the antibiotic era, we cannot see it's too rarely, but you should know that this one kind of the sepsis is the tonsillogenic sepsis. Maybe a late form, maybe early form. The late form is continuing and other complications. The early form, septic infection, generalization related any stage of tonsillitis. The treatment of the tonsillogenic sepsis, it's that we should just closing the connection. I mean, just closing internal jugular vein and tonsillectomy. We should eliminate the infectional focus. And that's why we should just do ligation and we should do tonsillectomy. And after that, after the intervention, surgical intervention, we should do the antibiotic therapy, desintoxication therapy, and rising of immunobiologic reactivity. Now about the chronic tonsillitis. Chronic tonsillitis is general infection and allergic process which local inflammation of tonsils and refers to repeated attacks of acute tonsillitis. Chronic tonsillitis is a persistent infection of the tonsils which is usually caused by bacterial infection. Recurrent tonsillar infections sometimes lead to enlargement of the tonsils, which is often chronic. It can cause tiny stone formation or even cause small pockets formation which shelters bacteria. Despite the treatment of acute tonsillitis, it may cause chronic inflammation of the tonsils as a result of the repeated infections which have formed a crypt of the infected tissue on the surface of the tonsils, providing a niche to the bacteria to multiply or remain out of the reach of the antibiotics. Etiology of chronic tonsillitis is sometimes we can see this in preschool children and infants. The common cold virus or flu virus is often causes the chronic tonsillitis. In adult and adolescent, it's more likely to be caused by bacteria and Streptococcus, Staphylococcus pneumococci, and Haemophilus bacteria. Pathogenesis of infection disease in the tonsils has its basis in their anatomic location and inherent function as organs as immunity processing infectious material and other antigens, and then becoming paradoxically a focus of infection or inflammation. The pathological inflammatory changes are localized in the epithelial coat of the falces and in the walls of the tonsillar lichen, in their parenchyma and the stroma, and also in the paratonzillar connective tissue. The squamous epithelium of the crypts comes off in scales to form fetid caseous masses plugging in the crypts and containing numerous bacteria and leukocytes. The crypts become a most convenient place for the retention and propagation of virulent streptococcus and staphylococcus, whose vital activity keeps up in the inflammatory process in the tonsils. The tonsils of most adults in chronic tonsillitis are small. In children they are enlarged, but hyperplasia of the lymphoid tissue of the pharynx is considered normal for children. The surface of chronically inflamed tonsils can be loose, especially in children, but in most cases the tonsils remain smooth. The presence of fetid caseous matter or prevalent plaques in the tonsillar lacuna is an important and the most common sign of chronic tonsillitis. The lacunar contours are usually taken for diagnostic studies with a spatula. A common local sign of chronic tonsillitis is the enlargement of the regional lymph-expressing nodes. It is international classification. It's divided the chronic follicular tonsillitis, chronic parenchymatoses, and chronic fibroid tonsillitis. It's characterized by recurrent acute attacks, and etiology is related with the recurrent acute tonsillitis. It's the subclinical infection of tonsils and chronic infection in sinuses or teeth. Okay, now in this picture, in this slide, you can see the classification of chronic tonsillitis, which we demand. It is the this classification is not valid in just the West world. I mean, it is your program because we will demand on you during the exam such of the classification. This classification is the post-Soviet countries and just the Russian Federation's systems classification. It's based on them. They also classified chronic tonsillitis as a 3 types. There are Lukovsky, Preobrazhensky, and Soldatov classification. Excuse me. Lukovsky's classification, he's divided it compensation, subcompensation, and decompensation stages. So that classification, he is divided it specific and unspecific. Specifically, for example, the tuberculosis, syphilis, scleroma, all this. In that classification, all this chronic tonsillitis may be seen during these diseases, but unspecifically it is divided the compensation and compensation classification. But we are using most accepted classification. It is the Preobrazhensky classification. Preobrazhensky divided it into 3 types: just a simple, toxic allergic 1, and toxic allergic 2. During the simple chronic tonsillitis, we only can see just local sign. Local sign, we mean just excessive tonsillar debris, which we call this the tonsillitis. The sign Gize, we mean just the paratonzillar erythema. Sign Zak, it is the paratonzillar edema. Sign Preobrazhensky, it is the paratonzillar infiltration and hyperemia, scarring between the triangular plica and the tonsil, lymph, increasing the lymph nodes, and painful lymph nodes during the palpation. During the toxic allergic 1, the simple sign, except the simple sign, will be just a toxic allergical sign, such as the periodic subfebrile fever, tonsillogenic intoxication as a fatigue, periodic joint pain, cervical adenopathy, functional disturbance in heart during the severity. But all these laboratory studies are unsteady. I mean, just the patient have just a pain in the heart, but if we will do but if we do just any EKG, we can note any sign of it. But during the toxicologic's 2, the simple plus toxicologic's 1 symptoms and toxicologic's second degree symptoms is occurs. For example, the functional disturbing in heart which marked in EKG, pain in heart area within an extra severity period, tachycardia and tachyarrhythmia, subfebrile fever, functional disturbing acute and chronic inflammation of the kidney, heart, liver, joint, vascular system, and other organ and system which are registered in laboratory workup. Okay, we can differentiate them, we can distinguish them. Okay, during the simple, it is the angina marked in 3% patient's history. The toxicologic's 1, the simple and local sign, and women unsteady functional disturbing in other organs. Toxicologic's 2, women just the toxicologic 1 symptoms and plus organ disturbing other functions and complications also occur. Now about the associative disorders, which can occur the local associative disorders in general. Local women just the paratonzillar abscess, parapharyngitis, pharyngitis, we discussed it. And general, it is the tonsillogenic sepsis, rheumatism, secondary disorders of the heart, kidney, joint. In favorable conditions like chilling or reduced body resistance each other, these factors may cause exacerbations. Such as acute tonsillitis, paratonzillar abscess, and a number of general complications, for example, infectious polyarthritis, rheumatic fever, nephritis, and others complications can occur. Our diagnosis is based on just a generalized inflammation of the pharyngeal valve, the swollen tonsils that project from between the pillars of the fauces and exude white or yellow follicles. The purulent drainage when pressure is applied to the tonsillar pillars, possible edematose and inflamed uvula and rula. Culture may determine the infecting organism and indicate appropriate antibiotic therapy. The leukocytosis is also usually present. Differential diagnosis rules out infectious mononucleosis and diphtheria. It's very important to distinguish it with them. Treatment, untreated strep throat can in rare cases result in rheumatic fever. Treatment of tonsillitis usually involves keeping the patient comfortable while the illness runs its course. This supportive care includes the bed rest, drinking extra fluids, gargling with warm salt water, and taking pain relievers, usually non-steroid anti-inflammatory drugs to reduce the fever. Tonsils and throat infections are treated with the symptom relieving measures to make you feel better and, where appropriate, medications to combat the infection, as a salt water gargles, increased fluid intake, anti-inflammatory medications, and rest can help lessen to severity of your symptoms. Antibacterial agents are used for tonsillitis treatment or throat infections caused by bacteria, but they have no effect if used to treat infections caused by a virus and can even be harmful. If the throat culture shows Staphylococcus pyogenes is present, penicillin or other antibiotics will be prescribed. Another conservative treatment it is the washing of lacunes, or we call this the lavage of palatine tonsils. We are using the shrinks. Tonsils lacunes with disinfectant solutions. After that we are using the suction. Sometimes there is the indication for the tonsillectomy. In this slide, you can see the step of the tonsillectomy surgery. The preparative management is carried out in outpatient conditions. In the majority of cases, the operation is performed under local anesthesia with the patient in the sitting position. Whenever necessary, tonsillectomy is performed under inhalation intubation anesthesia. The most common complication of tonsillectomy is bleeding from the tonsillar fossa during the first day after the operation. The discharge from the mouth should be constantly controlled. It is necessary to remember that blood can pass into the esophagus. In suspecting bleeding, the patient's pharynx should immediately be inspected and blood clots, if any, should be removed and examined thoroughly. Okay, the first pictures we can see the incision. Then, secondly, we are inserting our elevation and we are elevating it. And with the sometimes during the surgery we are not too much using just the scissors, but sometimes we should use the scissors for the just during the scarring tissue. And the last stages, it is the tonsillectomy. The surgical removal of the tonsils is called tonsillectomy. It is the indication for this surgery. It is 3 to 5 episodes in 1 year, or at least 5 episodes per year for 2 years. At least 3 episodes per year for 3 years. Actually, this indication is changing in the countries. It develops. It depends on the insurance system of the community. Now, in that pictures, the previous pictures we showed you just a classic tonsillectomy operation, but now you see the patient under general anesthesia. You see the tongue is located superiorly. It's the mouth gag, you see, and we are doing this surgery with with the calculator. Just the cutting we are using with the calculator. That's why you can see scar tissue. The surgical, it's more contemporary methods, which is using just a calculator. Surgical removal of one more tonsils, usually through the electrical cauterization. Here we can see. After the tonsillectomy, we can see such of the view, the white patch in the arch. In this picture taken a week after tonsillectomy, the tonsils have been removed and the whitish discoloration in the tonsillectomy bed, but it is the scar tissue which forms postoperatively. This is normal after a tonsillectomy and should not be confused with the infection. The site where the tonsils were removed should heal within 7 to 10 days. Postoperative symptoms include, but are not limited to, the swallowing problems, throat pain, ear pain, vomiting, fever. But most dangerous one is the bleeding. Okay, a little bit about the adenoid tissue. Adenoid is so popular problem. It's so common in children. It is the pathological hypertrophy of nasopharyngeal lymphoid tissue sufficient to cause abstraction of nasopharynx or station dysfunction. The adenoids are mass of lymphoid tissue in the roof of the nasopharynx, located just inferior to the sphenoid sinus and anterior to the basis of the septum. Laterally, the adenoids blend with the lymphoid tissue in the fossa prosimilia near the opening of the eustachian tube. The adenoids are present in all infants and children and start to regress just before puberty period. They are usually absent in adults. If you or your child's adenoids are enlarged, it may be hard to breathe through the nose. Large adenoids produce the nasal obstruction, mouth breathing, nasal voice, snoring, and restless sleep, and others problems. In that slide, we can see just adenotomy surgery, the classic adenotomy. This instrument we call Beckman adenotome. We are inserting the adenotome through the mouth, and we are performing this surgery, which is too popular in the children, among the children. Okay, that's it. Thank you for your attention. Good luck.